And are we all set, Sean? All right. So welcome back to CMS Grand Rounds. This is part 2 of the topic of, when is surgery the right choice and what do I need to know? So part 2 of today's series, the learning objectives are as follows. So by the end of this activity, you should be able to identify the intensity and variation of surgical care at the end of life based on the cohort study. Number 2, recognize that frailty is one of the best predictors of post-operative complications. Number 3, recall the risk analysis index, the RAI, and list some of the variables, 14 variables, on the weighted scale. And finally, recognize that surgery for the frail patient is never low-risk surgery. So I think that is a great take-home message. Surgery for the frail is never low risk. So this part 2 session actually does align with the CMS goals to empower patients and clinicians to make decisions about their health care and have important conversations, ushering in the state flexibility and creating opportunities for local leadership, supporting innovative approaches to improve quality, accessibility, affordability, and finally, improving the CMS customer experience. Customers being both the beneficiaries who we serve, but also the clinicians who we work with, who provide care to our beneficiaries. So this session is also, as with part 1, eligible for CME credit and can be accessed as an enduring material that you actually register for the Medicare Learning Network. And the link is provided here. And importantly, so we are here to learn together and understand what the evidence tells us about surgical risk and to think about what the opportunities are to put in place the vehicles, the strategies, and enable the clinicians and facilities who are providing the care that we and the patients rely upon to actually have the best available evidence and to at times even pause before a procedure is done. Earlier we learned that there's opportunities to provide high quality care and the elements of the geriatric surgery verification program that really highlights opportunities from the facility's perspective, and as clinicians, as surgeons, it is, I've learned from my colleague, Dr. Couch, how critical it is to really be in an environment providing care that actually supplements and wraps around all that you do during the course of a surgical encounter. So there is so much to this, and we do have upcoming events in March and also the quality conference last week in February. And Dr. Couch actually did introduce our speakers in detail, but I want to turn the podium over now to Jason Johanning, who is a esteemed colleague and really at the cutting edge of the science, as well as the putting in place opportunities for clinical practice that improve outcomes for our beneficiaries. So Jason, I will turn it over to you. And thank you for being with us today.
Thank you, Dr. Lane. Today, we're going to discuss the case for frailty. I have a disclosure that I hold intellectual property through Future Assure LLC. This talk may generate a little bit of angst, but I'm fine with that. I think we have to talk about these issues. And most importantly, if there are surgeons in the audience, I am not going to tell you who you should and should not operate on. Now, I was chief of surgery in Omaha, and we had a problem. We had elevated mortality findings based upon risk-adjusted outcomes. And as a chief of surgery, you get visited and asked to improve those outcomes. And I wanted to place this in the context of being a geriatric scholar, that this is not uncommon. We saw elderly patients going through our system not getting optimal results. And to put Omaha in perspective, we're going to see more and more of this as we see the silver tsunami. And what Omaha gave me was a burning platform to implement unique aspects of frailty assessment that improved outcomes, and we'll discuss that. Importantly, to put this in perspective, as Dr. Rosenthal pointed out previously, fully 1/3 of CMS beneficiaries have a major surgical procedure at the end of their life in the last year. And importantly, this is associated with impacts that most people tell us they do not want to have. Specifically, more admissions in the last year of your life, longer length of stays in the hospital, and greater ICU length of stay. And this is all of the things that we saw in the Omaha data. Importantly, and this is key, as our population ages, healthcare providers' thresholds for intervention for elderly patients will probably change. And the question is, what are the guideposts that we're going to use to determine that? Now, based on the VA data, we knew that we had to identify that 1 out of 10 patients coming to our clinic who are at high risk for poor outcomes. If you look here, clearly 9 out of 10 patients will go through our system and have good outcomes. The question is how do you rapidly identify that 1 out of 10 patient in a busy surgical clinic where you're trying to get through your day as a surgeon? Unfortunately, we as surgeons and anesthesiologists in patients have that Lake Wobegon effect. All the surgeons are strong, the anesthesiologists are good looking, and all the patients are above average. And most patients do believe they're above average when you talk to them. The question is, again, how do we identify that 1 out of 10 patients? Well, one of the challenges in the clinic setting is you don't have time to get on a computer and log on and do a risk assessment that takes 10 to 12 minutes. It needs to be rapid, it needs to be chalkboard math so that you can identify that patient who's sitting in front of you rapidly. And why is this important? Well, Dr. Robinson, as well as Dr. Segev and Dr. Macri, who are some of my Janigan cohorts with regards to surgical care, has demonstrated this is really important to the patient in front of you. If you are frail and you need to undergo a major operative procedure, you will have nearly a 1 in 2 chance of having a major postoperative complication. And yet I challenge surgeons routinely to ask themselves how often are they honest with their patients and tell their patients you have a 1 out of 2 chance to have a major complication with this operation, and let's go do that operation. Putting this into reality from a financial perspective, if you take 24 patients who are non-frail and give them a colorectal operation, cost of care at 6 months is $800,000 in the VA system. Nobody gets discharged to a skilled nursing or extended rehab facility, and there's a 4% 30-day readmission rate. However, if you're frail, cost of care triples, 60% of patients go to a non-home destination, and a full third of those patients get readmitted. Again, very simple, measuring frailty is very powerful. So what's our big, hairy, audacious goal? It's pretty simple. For every single patient going to the operating room, I want surgeons to ask a singular question. Is my patient frail? Now, frailty has been conceptualized, and we have a good roadmap now based upon a recent consensus paper into 2 basically camps. One is physical frailty, where you must measure grip strength and walk speed. The other one is the cumulative deficit model. And it was very clear, if you're in a clinic setting and you want to do this rapidly, it's probably easier to ask questions rather than measure grip strength and walk speed. And so we chose a tool out of eprognosis.com based on the question, if you have 6 months left to live, would you want a major elective operation? And in general, when I ask audiences, I don't see too many hands raised that they're ready for that major elective operation. And so we chose the PROROC index and modified this to use in Omaha, and we named it the Risk Analysis Index. We made it mandatory for our surgeons to measure this, and in order to book an operation, they had to give us the score of the RAI. We then conducted weekly reviews out of the Chief of Surgery office. Either myself or a designee would review those patients who scored high, and then we would simply go to the parties treating the patient, either the anesthesiologist or the surgeon or even the residents, and said, what's your goal here? What are you hoping to accomplish? Is there anything I can do to help you to ensure an optimal outcome? It's what we graphically refer to as the surgical pause. Again, 90% of patients will go through usual care, and the 10% of people that we identify as frail, we either further risk assess, we do risk-informed shared decision-making, prehab, or, and this is the key, we don't say we're not going to operate and not care for you. We say we are going to continue to care for you, but a big operation may not be in your best interest. So what happened? We had a major impact to our system. There was a marked decrease in mortality, but more importantly, it was sustained over time, demonstrating a systematic effect. 180-day mortality fell from 23.9% to 7.7%, and that threefold survival advantage was present even after controlling for age and frailty. Importantly, too, we altered the way palliative care was integrated into our system. We had, with this rapid identification of frailty, surgeons actually ordering palliative care consults, not postoperatively in the ICU when complications were occurring, but preoperatively in order to give the patient a realistic assessment of what they were about to encounter. So we knew something happened in Omaha, yet Omaha is Omaha. It's not the rest of the United States. And so I needed a collaborator who could tell us what really happened in Omaha, was this a valid result, and could we do it elsewhere? And so I'd like to bring Dr. Dan Hall up to talk about his work and how we've progressed.
So thank you very much for this opportunity to speak. Jason and I started working closely in about 2014. I'm the nerd. I'm the one that came up with those statistical assessments of what happened there in Omaha. And what I want to try to do in the next 20 or 30 minutes is to review a little bit of what we've done in the years subsequently to really validate the risk analysis index in a variety of different clinical contexts, and to show you how we've replicated some of those results in different systems. So first off, the risk analysis index by review has 14 variables, including age, sex, unintended weight loss, poor appetite, cognitive impairment, activities of daily living in 4 dimensions, where you're living, and then some comorbidities with regard to renal insufficiency, congestive heart failure, dyspnea, and a history of cancer that is not in remission. And what we found in our original work out of Jason's cohort at Omaha, we found that the tool had a remarkable degree of discrimination with a C statistic between 0.7 and 0.8, and effectively risk stratified patients. One can calculate the risk analysis index either by relying on registry data variables like in the VA Surgical Quality Improvement Project or the ACS NSQIP. These are high quality research registries with adjudicated, trained nurse abstractors with high quality understanding of what has happened by reviewing those charts, and is really great for doing retrospective studies. But in addition, retrospective studies aren't going to really impact your daily decision making. And the challenge, as Dr. Johning pointed out, is how can you deliver this identification of a high-risk patient at the point of care, at the time that critical decisions are being made. So we were able also to measure and calculate the RAI based on a survey. It takes in the initial implementation, less than 2 minutes to complete. It has a greater degree of granularity than many of the other frailty metrics that are out there. It predicts 180-day mortality with reasonable discrimination. There's also good correlation between these two, so we can begin to kind of utilize our various data points to make better inferences. But I do want to point out one thing. I've played fast and loose with the y-axis. We can and we do operate even on the most frail patients in our clinics, and only 40% of those die out to about two years here. So it is possible to continue to operate well on these patients, but there is an opportunity for better patient selection. So based on that preliminary work, we had the understanding that the RAI seemed to work. But there were questions that remained that needed to be answered, including the fact that the scoring system was adopted from a nursing home population and never really calibrated or validated within a broad surgical population. We were also limited in our validation to a single VA hospital. So what about other VA hospitals? What about non-VA hospitals? And given the fact that the VA hospitals care primarily for men, what about women? In addition, we ran into some initial objections from our surgical colleagues. Number one, they were concerned that the subjectivity of the RAI was a problem and that they wanted us to add the objectivity of biomarkers to try to improve its performance. In addition, they sort of said, yeah, frailty is really important for those big operations, the esophagectomies and the pancreatectomies that we do, but I can get anybody through a hernia operation. We'll see. We didn't have data to be able to try to understand that. So this is what I've been working on for the last few years. I first got my hands on a sample of about 500,000 veteran patients from the VA Surgical Quality Improvement Project. This is a representative sample of 4 years of VA's book of business. And I took the original RAI score, calculated it, and lo and behold, it worked pretty well with decent discrimination and relatively decent calibration as originally intended, as Dr. Johning used in Omaha. What you see here in the red line is the predicted mortality, and then for each integer value of the RAI, you see the point estimate and the confidence interval of what the actual observed mortality was. But I thought that we might be able to improve this a little bit, so we did some math and recalibrated the system, and the discrimination improved to a C-statistic of 0.84, but what I think is more impressive is the remarkable improvement in calibration. The model still does, in fact, overpredict mortality at the higher scores of RAI, but up into a predicted and observed mortality of 40 to 50%, it tracks really closely, and I would suggest that this is where we're making most of our decisions down here, and this is a reliable tool that I think can begin to influence preoperative counseling. We then applied this new recalibrated system into the ACS NSQIP data set and found that, again, it had good discrimination and good calibration. And then we did a subgroup analysis between men and women to show that it does work in women as well. This was published about a year ago in Annals of Surgery, and it essentially establishes the risk analysis index as the single most validated measure of surgical frailty available in the literature right now. In addition, I wanted to understand whether biomarkers would help. So within this 500,000 sample of veteran patients again, we had a variety of biomarkers that we added into the model to see what would happen with discrimination. So over here you have the original RAI scoring, and you can see that when we recalibrated it, it improved. Adding BMI and creatinine doesn't really improve the discrimination of the tool, but adding hematocrit, albumin, or all of them together does make a statistically significant improvement in the model's discrimination. However, the question is, does this make any clinical difference? And I would argue no, as follows. That's the curve with just the RAI on its own, and this is the improvement that you find by adding hematocrit to it, which gets you most of the improvement. All of the improvement happens in this upper part of the score. It really doesn't change where we're seeing most of the patients and most of the counseling would happen. So I would suggest this is evidence to say that although we really like the precision and the objectivity of biomarkers, it's not needed for this particular purpose of identifying high-risk patients at the point of care. In addition, we've done some additional analyses to show how the risk analysis index predicts outcomes, most particularly complications and mortality, and the interaction between the two of those that we call failure to rescue. And what you see is that as the risk analysis index increases in different strata, the probability and likelihood of suffering a complication increases. And in a statistically significant interaction, if you are more frail and you suffer a complication, you are more likely to die, which is essentially a failure to rescue. These are the people who suffer the worst outcomes in our healthcare system. In addition, I wanted to try to get at this question of, does it matter just for the big operations, or is it all for all of the operations? And this was just published in November in JAMA Surgery with some popular press interest in it. To answer this question, we noted that in that sample of 500,000 veteran patients, 90% of that record, 90% of the book of business for 4 years in the VA came down to just 566 CPT codes. We divided those up according to surgical specialty, sent them off to a panel of surgeon experts and anesthesiologists to rate each of them according to their physiologic stress from low to high. And what we ended up with a 5-point score where the low stress procedures like cystoscopy or a ganglion cyst, level 2 stress procedures would include an inguinal or an umbilical hernia or some kind of joint arthroscopy. Level 3 procedures would include cholecystectomy, carotid endarterectomy, or a joint replacement of some variety. Level 4 procedures include the big general surgery procedures like an open colectomy or a prostatectomy or a pulmonary lobectomy. And then again, these big, massive cases, level 5s, would be the abdominal aortic aneurysm, the pancreas operations, or the esophagectomies. And here's what we found. What we found was that among the robust blue, normal or average RAI scores in red, we saw absolutely low mortality rates. These are the ones that we quote to our patients. This is the typical outcome that you can expect when you come to a high-quality center, and that they indeed rose a little bit over the physiologic stress of the category. But if you were frail in green, or you were very frail in orange, your mortality, regardless of the operative stress, was at least 10 times higher than those who were normal or typical, right? Is this because the surgery of doing a ganglion cyst operation is causing the patient to die? I don't think so. I think that this here in level 1 and 2 procedures is simply demonstrating that the RAI is doing what I've told you it does. It assesses medium-term risk of mortality. These are the people who have entered the last season of their life, and it's not surprising that in 6 months, a third of them may be dead. But in these procedures, level 3 and 4, where you see this precipitous increase, I suspect that the stress of these procedures is high enough to occasion their death. By providing this additional stress, we are exhausting their reserves and potentially bringing their demise sooner than it would be otherwise. And really interestingly down here, you notice that the orange line comes down. We think that this is because surgeons are always thinking about these really high-risk procedures, and it's there that we do really good case selection. But we think that we can get anyone through these procedures. But I would suggest that these data are a strong argument that we've got a lot of good opportunity to do better case selection for these kinds of procedures moving forward. And the bottom line of this story is that there's no such thing as low-risk surgery in high-risk frail patients going forward. If you consider that surgeons find that if you have a greater than 1% mortality rate, that is a definition used in the surgical literature for a high-risk procedure, any kind of procedure in frail patients has 10 to 20 times that amount, where you're having 10 and 20% mortality at just 30 days going forward. Now, I want to shift a little bit and tell you about some of the implementation results that we've had with regard to the surgical pause. As Dr. Johning suggested, the first step in the surgical pause is to try to screen for frailty with the RAI. And we did this at the University of Pittsburgh Medical Centers beginning in July of 2016. We took the questionnaire, we ran it through our QI shop, we changed the language to make it a little bit more easy to be patient-facing. We distributed a single-page questionnaire to patients in advance of their arrival at the surgical clinic, either as they were checking in or in the mail beforehand, and we asked them or their surrogate to complete that either on paper or on a tablet in the time that they were waiting for their surgeon. And then a medical assistant would verify the responses, had the opportunity to override any of the responses that seemed to be inaccurate, and plugged it into an online calculator to be able to generate the RAI score. And to help us drive this into practice, we had the support of our most senior leadership, who were wanting to move from doing lots of stuff to lots of people to doing only the right stuff for the right people, moving from volume to value. And they basically hooked up the surgeon's productivity bonus for the year. They weren't going to get that unless they did it on 80% of all of the patients newly presenting in their outpatient surgical clinics. It took us about 3 months to get there overall, above our 80% goal, and we found that it took only 30 seconds median to accomplish this goal and did not disrupt clinical flow at all. This is a report that just has been accepted for publication in Annals of Surgery and reports our experience in the first 6 months of about 50,000 patients, but subsequent to that time at UPMC, we've done it more than 350,000 times, again, with a similar kind of 30 seconds to make this happen, and it is not disrupting our clinical flow. So rapid and eminently feasible, but does it work? Yes, it works. Discrimination, again, as we would expect in the low 0.8s with decent calibration. This also is impressed with Annals of Surgery coming forward. Now, for the first year, we didn't ask the surgeons to do anything different at UPMC. We were just trying to socialize measuring and seeing whether we could get the score and then showing them with their own data that this was actually an effective tool to risk stratify their cohort. But we chose for the second year a threshold of action of an RAI value of 37 because this corresponded to the highest risk 10% of the population for whom you could expect at least twice the average 6-month mortality, twice the rate of 30 and 90-day readmission, twice the rate of long-term ICU stays. And at that threshold, you had only modest positive predictive value. It wasn't a gold standard for measuring frailty. It was just trying to identify the people that you would pause and take a closer look at. But it had really strong negative predictive value. The point being that if you score low on this tool, you can move forward with usual care and you can expect the kinds of outcomes that are typical and the kinds that we quote to our patients most of the time. It's safe to operate on these folks if they have a low RAI score. Step 2 is to try to do something about the frailty. And as we've heard a variety of different standards, the 3 that we've been focusing on is if you're frail, you can have some kind of interdisciplinary review. And Dr. Johning showed that how that approach in Omaha decreased mortality from 25 to 8%. You can also engage in a kind of goal clarification. And at UPMC, where we've sent a lot of these people to an interdisciplinary care clinic where they have additional training in palliative care communication techniques, we've been able to show, and I'll show you a little bit more data on this in a moment, that we've changed the care plan among the frail in 1 out of 5 people who come to that, who would have otherwise gone to surgery. 1 out of 5 end up choosing a non-surgical option. And for those that decide to go forward, you have an opportunity to prehabilitate them. And in some pilot work that I've done at the VA, I've shown that in the 3 to 6 weeks before surgery, but through exercise and balance training, you can increase endurance, gait speed, respiratory pressures, and functional performance on the whole. So what happened? In the VA Pittsburgh, we started measuring frailty in December of 2015, and exactly the same pattern in the observed to expected mortality rate happened as we'd observed in Omaha. I have not had the opportunity to do the multivariable analysis here for lack of statistical resources, but I would suspect that we would find something similar. At UPMC, we're still working on trying to wrangle that data. We unfortunately have a healthcare electronic record where our preoperative values are in one EHR and our postoperative values in another, and we're struggling to have them talk with each other. But within our own local cohort of ACS NSQIP patients, in this period of time, there were 6,357 of them. We started, as I said, screening for frailty, but not doing anything about it in July of 2016. We started to ask them to do something different about it in July of 2017, but our best practice alerts in the electronic health record were not sufficiently coercive, and change was not happening in the way that we wanted. They weren't accomplishing what we wanted them to do. We redesigned that, and in February of 2018, we had a different set of best practice alerts, and keyed to that time, we found that before and after that February 2018 date, mortality, 365 mortality, fell from 6.6 to 4.2%. That's an adjusted odds ratio of 0.67 with a marginal effect of cutting mortality by 1.5%. This is with a really light touch. We didn't have all of the standards in place that Dr. Rosenthal described earlier. This is just basically letting the surgeons know we're watching you, and we're watching you especially on the patients who score high on this risk analysis index. And this is the kind of effect that we've been able to observe thus far. Here's some of that data regarding changing the care plans. From February 1st to September 20th, 2018, we screened close to 50,000 patients, of whom about 4% had a score above 37. And then we asked the surgeons, are you planning to do surgery on these? Because a lot of them are there to have earwax disimpacted, and they're not going to go for major surgery from that ENT option. But about a quarter of them were planning to go forward. And this is what we asked them to do. We asked them to either document a more robust shared decision-making process that is informed by the frailty-associated risks identified by the Risk Analysis Index, or you can send them to our interdisciplinary anesthesia-led preoperative medical home, the Center for Pre-Surgical Care, or send them back to the PCP to look at their risk assessment. These are not mutually exclusive. You can see that 86%, the easiest way out of the trap of these coercive best practice alerts would be to say that they did a more robust shared decision-making process. And I can't tell you really what they did in that shared decision-making process. It's a study that I'd like to do, but I haven't had the opportunity yet. But I can tell you a little bit about what happens when they go to the solution that we built for frail patients, which is the CPC. What we found is that 1 in 5 chose non-operative management. This is a huge culture change for UPMC hospitals. Fully 60% of those the others had some sort of delay or change in their plan to either have a less complex operation or to delay the operation that they had in mind until some achievable, discrete goal for rehabilitation was achieved. And only 1 in 5 went through without any delay moving forward. And among those that went on to have the operation, we have low sample size at the time that we did this analysis, but there's a suggestion that there's about a 1-day reduction in their length of stay. In addition, I've run several pilots at the VA Pittsburgh on trying to see whether we can prehabilitate patients. And in a sample of 39 patients scheduled for abdominal or thoracic surgery, a combination of a home and hospital-based exercise regimen with an exercise physiologist that was focused on strength, endurance, balance, and coordination for the kinds of movements people need to make after surgery. How are you going to get out of bed and to the bathroom if you've got a big abdominal incision or a big thoracic incision? We try to work them out beforehand to get that moving, and we showed that in as little as 3 weeks, we had not only statistically significant, but clinically meaningful improvements in gait speed, 6-minute walk test, maximal expiratory pressures, and extended timed up and go, suggesting that there is an opportunity for the motivated patient. I did find that to get that 39, I had to screen about 120 because if they've been a couch potato for the last 40 years, they're likely to want to remain a couch potato, even in the context of showing them their risks. But for the motivated, there is an opportunity to improve. Now, this begs the question of frailty and its applicability outside of the surgical setting. Surgery is important, but it's not the only place where frailty might be relevant. And we've had the opportunity now, because we were measuring the risk analysis index on everybody presenting to outpatient surgical clinics. And we asked the question, does it work in patients who are not having surgery? I've already shown you these data already, which are the people who had major surgery as defined by inclusion in ACS or VASQIP data sets. These are people who had minor procedures like having their earwax removed or a joint injected, an office-based procedure of some variety but not requiring anesthesia, or no procedure at all. Again, the discrimination is robust, actually more robust in these non-surgical populations, and it effectively risk stratifies people, suggesting that this might be of use outside of the surgical setting. In addition, our colleague Shipra Arya, who's at Stanford, has developed a crosswalk to be able to calculate the risk analysis index based on variables in CMS data and in the Health and Retirement Survey, showing again in this sample of 21,000 that it is well calibrated and effective at risk stratifying those patients. And then in addition, she was able in a subset of these patients to take a look at, this is only among the frail, and among the frail, these are people who had no stressor, no traumatic injury, and no surgery. This is how they did over 365 years. And these are the folks that had an injury, and these are the folks that had surgery, showing that, again, the interaction between the stress of surgery or the stress of injury in the context of decreased physiologic reserve leads to the overwhelming of that physiologic reserve and a much more increased risk of mortality going forward. So this is, again, further evidence to suggest that this tool, and the magic is not in the tool. Any tool could do it. What is great about this tool is that it's feasible and quick to be able to identify rapidly in real time the folks that you may want to pay closer attention to. In addition, there's been some increased data about the cost associated with the risk analysis index. The RAI has been implemented at about 12 different hospitals across the country, including Maine Medical Center here, which is reporting their hospital-based costs. That in univariate and multivariate analysis showed that frail patients had more cost directly, indirectly, the total cost, and interestingly enough, the net income was down for the hospital because although the costs are higher, the reimbursement is exactly the same. But also pay attention that this is primarily among a few of the surgical specialties, but not in some of the others. So neurosurgery does not seem to have this effect, and there's an opportunity to perhaps be a little bit more tailored about where frailty within the surgical disciplines makes the most sense. And then finally, UPMC, as you may know, is an integrated delivery and finance system, which means that we own and operate the hospitals and the physician practices, and we also have a health plan. And in about half of the patients that we treat in our hospitals, we are the self-insurer, so that we actually have charge data on those. Here's what we found. Now, this is a little bit challenging because UPMC is not wanting to disclose the actual dollar figures on which these proportions are based. So let me walk you through it here. Everything is keyed to this total cost among the non-frail. This is both people who had surgery and people who did not have surgery. This is that entire cohort that I showed you before that had a minor procedure, no procedure, or a major procedure. And you can see that the costs are binned out. All of this adds up to 100% for outpatient hospital, emergency room to inpatient, medical and surgical encounters, inpatient surgical encounters, home care, and skilled nursing facilities, all adding up to 1%. But if you stratify looking at this same set of costs, the frail cost 3 times as much, the very frail cost 5 times as much, right? Now, if you look again, this is only the patients who had surgery. It's a little confusing because it's now 6 times as much. People who have surgery cost 6 times as much as those, the whole crowd. And most of that is because of the cost here of the inpatient surgical encounter, which is 4 times the average cost all on its own. But notice that the cost of doing the surgery does not change with frailty. We get the frail through with the same cost, but where the cost increases is in these other things like skilled nursing facilities, which means that the total cost for the frail is 30 and 60% more than the average moving forward because of these other post-acute charges, which we've basically been blind to when all we have is our electronic health records moving forward. So with that, I'd like to turn it back over to Dr. Johning, who will talk about some of his additional implementation work.
So we're going to return to the burning platform, and we're going to talk about an experience that I recently had when I was acting Chief Medical Officer for Vision 23, which includes approximately 8 hospitals that I oversaw as Chief Medical Officer. And some of you may be familiar with the SAIL diagram that the VA previously used that is now going to be done away with. But to give you a perspective, this is what I faced. We had a standardized mortality rate, which is essentially all our inpatient care, and our standardized mortality rate for 30 days. We were a low outlier and not getting good results. Maybe we could use frailty and risk assessment to improve those results. Now, to put this in perspective, everybody didn't like SAIL, but the one thing that SAIL did to our mortality rates across the VA is we saw over 5 years improvements in mortality in the whole VA system of 8.57 and 6.38% respectively. The point being here is that if I was going to change this metric, I didn't simply have to improve our system. I had to improve it in addition to the rate that the rest of the VA was improving. Now, I think we've hopefully convinced you that the eyeball is not necessarily accurate at identifying that 1 out of 10 patient. However, let me say that it's not just surgeons who have an issue. If you look at oncologists giving chemotherapy and you ask them to rate people by that Karnofsky performance scale to determine who's going to have complications, they are no better than chance at identifying those patients. Yet if you use a standardized frailty assessment tool, it sorts patients out very well. Cardiologists, same outcomes. You cannot do a foot-of-the-bed assessment just by an eyeball test and get the same outcome that you can with a standardized, objective frailty assessment tool. So I firmly believe that you have to have some structured assessment with which to guide your risk stratification and future care decisions. So what I did is I gathered all our CMOs, QMOs from the sites. We had a real-time, face-to-face meeting where I said, you have to give me 3 things you've done to try and address the mortality problem and 3 things that you're going to do in the future. And I can tell you that we were across the board everywhere. No one site had the same concerns or the same issues. But the one thing that I promised to them is that I was going to give them a real-time inpatient risk tool, similar to that big, hairy, audacious goal that we're going to measure frailty on everybody. I said I'm going to risk stratify every single one of our inpatients within our system on a daily basis, and I'm going to give it to you via email. And that's what we did. Now, we also looked, I firmly believe we have to have data on which to base this. We assessed our CDW, or corporate data warehouse, for all those patients who actually died during the previous year and compared them to our current inpatients. And what you can see is, going down, looking at these frailty variables, they were markedly higher in the patients who died than in those who were our current inpatients, which said, gosh, we should be able to identify our high-risk inpatients. And in fact, this is our simple little tool that we put together. Demographic information. We also created here ward transfer mortality is one of the big issues that we had as patients going to a higher level of care. And then we also looked at comorbidities, a care assessment needs score, which is just a simple risk score based upon the EMR. But then we also had our frailty score. We used biomarkers because we easily had that available. We used albumin and hematocrit. We also identified use of care, so home-based primary care. We also used our number of ER visits within the last 2 years. And lastly, had the providers actually had a discussion with the patients regarding end-of-life care based upon our LST note or life-sustaining treatment note that is part of the VA initiatives to improve care towards the end of our life. What did we see? In 1 year's time, SMR 30, it still looks like it's a bad metric, but please recognize that we went from 18th to approximately 12th. We are mid-pack now in the 50th percentile, but more importantly, our inpatient care that I was most concerned about and focused on, our SMR, we are now 4th, and we are a low outlier for SMR. So in 1 year, we were able to drive not just a surgical system, but the whole scope of care by providing on a daily basis the people who could affect change at the hospital a real-time tool that risk-assessed patients, and we believe that giving the physicians the tool to risk assess and make decisions on is highly important. At the end of the day, we believe that risk assessment utilizing frailty is a value proposition. I can tell you we reduced costs in our surgical program in Omaha by 20%. Dan has just shown that there is no question that we can tell you who your high-cost patients are going to be in the system. And importantly, it's being shown that utilizing frailty to improve your system can provide significant quality-adjusted life years. This is from a health policy perspective that I want to talk about. One of the challenges is getting the general public to face the fact that we as physicians cannot alter your mortality at the end of the day. Everybody is going to die. And if people remember with the death panels, nobody wanted to talk about that. Yet with this silver tsunami, what you're seeing in the lay press is we're going to have to start talking about it, and people are willing to start talking about it. Dr. Robinson has been quoted in the New York Times talking about frailty assessment prior to operations. That was in 2017. And recently, Dr. Hall, as mentioned, was quoted in the New York Times for that no minor operation for frail patients. But I think the most important point of that article was the following quotation. What will your daily life look like right after surgery, or 3 months or a year later? What serious complications might arise? What will those mean for me? These are all questions that our public is starting to talk about, and I think the time is right for that tipping point to start looking at frailty in large systems. This is our RAI network that we've grown from a grassroots effort. I'd like to thank all those people and be happy to take any questions. So, do we want to do the panel now?
Is there a particular slide you're interested in?
Well, we'll find out. Probably can answer them without, but just in case you don't refer to it. You actually was answering, started to answer the question that I had, but you went from starting out with simple facts and rather subjective, and people kind of feel it's like, oh, you don't have a subjective background. In this last round, and I had a concern for another reason about that, you are building that back in, and you are populating your tool. This is a electronic clinical decision support tool, right? You're populating it with things like demographics and albumin and hematocrit. So now you're moving to objective plus subjective in your RAI, is that correct? So this was purely for our VA inpatients. We wanted to give people not simply the frailty variables, but to give them really what has been the trajectory of this patient over the last year or two. And so that's why, for example, the number of ER visits in the last year, and it was pretty interesting. Sometimes we would see a patient who had been in the ER 20 times, had refractory end-stage COPD, had been admitted 5 or 6 times in the last year, and guess what? we did not have an end-of-life care discussion with the patient on the books during that admission. So the point is not to use this tool as purely a risk assessment, but more, are we giving patients the right care? More importantly, when you improve outcomes or trying to, the other point was you could rapidly identify patients who were otherwise normal variables, normal hematocrit, normal albumin, had a simple pneumonia. And if they showed up as a chief of staff, if they showed up on your list as having died the night before, probably need to go to your clinicians and say, what happened to this 50-year-old who otherwise looked normal on paper and died?
Yeah, and then eventually, prospectively, you might be identifying patients in the morning in the wards who, because of you're giving every patient every day, you might be able to prevent them from bouncing into the ICU that afternoon, which is your long-term game. The other reason I like the objective criteria built into this is because it's one thing to have the subjective criteria work within the VA system and within a integrated health system, and I do come from that world. If you take that and drop it into a fee-for-service system, having some of those objective measures may give it a greater generalizability and more robustness. Just something to consider. Final question is, are you going to build this into the Genesis system?
So that's a good point. We do have the RAI built into Cerner at this point as part of a tool. We have not planned on building the real-time inpatient tool yet, although obviously there's an opportunity for that.
It's also programmed in Epic. We started at UPMC with the RAI using a bizarre workaround that I programmed in REDCap. But again, after a few years, we've programmed it into Epic, and is it available for share if you happen to use Epic in your healthcare setting at this point.
Hey there. So a couple requests and a couple of questions. The first request is I started to see if I could find the tool itself, the RAIC or the RAI-A, and I could not, because I'm interested in what the items are, so I'm wondering if maybe you could share a copy of it with Patrick. And then the other thing I'd like to see is I found this really, your list of high stress procedures ranked really interesting, and I think I'd be so curious to see what that looks like and how you calculated the stress piece. And okay, so my questions are, two questions. One, are you finding that surrogate caregiver responses are valid? And two, are there other optimal components of frailty assessment that are not in the RAA now? And of course, I could even speculate what those are because I wasn't able to see the full list. So there you go.
Right, so happy to make it available directly. The references that I quoted there are a number of places where the question items are available online. The most recent wording of it will be forthcoming at the end of the month in Annals of General Surgery, which shows that's reporting the implementation at UPMC and shows, you can see that purple page of the single page item. You asked a question about, are there other things that we could add in? Sure, there are things that the RAI is blind to. The question is what addition, is the juice worth the squeeze of adding those additional things? And so if you're able to build a data aggregator on a health record because the patient's in hospital, by all means use that information. My point about the biomarkers was that if we were to demand that people come up with an albumin or hematocrit, you wouldn't have the score at the time that the patient meets the surgeon for the first time, so that you get almost all of your predictive ability in the first 13, 14 variables. Adding additional variables on, the incremental improvement really doesn't change your ability to risk stratify in a clinically meaningful way. You had one other question, but I forgot what it was. Right. So I was really nervous about that. But the quality improvement specialist that I got joined at the hip with, Mary Kay Wisniewski, just sort of put her head down and made that happen, because I didn't think that we had any data to demonstrate that this would work. But those C statistics that I quoted for you include whatever noise is coming from the surrogates going forward. So again, I don't know whether it was the surrogate or the patient or the clinician that calculated any of those scores. Our sense is that the overwhelming majority were by self-report, but even in the setting of that noise, it was performing that well.
So just reminding people who are viewing by web, if you can submit any questions you might have to the chat box, we would appreciate it, and then Patrick or Wanda can actually read those questions. So we heard in Part A about factors, characteristics of a optimal system, and hear very clearly about the needs of infrastructure being up to speed, both, the personnel, but also how things work in the hospital. We also heard about the information that is really helpful in the hands at the point of care, in planning for surgeries, and the consequences of not doing so or not using that information. And there, we have the clinicians, the physicians, so we have facilities and we have physicians or clinicians. So I know, Frank, you've been thinking about this a very, very long time, and how to really pull this together so that the working pieces actually enable the better outcomes, thinking about what facilities can do and provide, raising the floor, if you will, as well as what clinicians should be focusing on, and what could be really helpful here in helping to drive this forward.
Well, first, to everybody here at CMS, Dr. Ling, Dr. Couch, thank you so much for having this day and focusing on all these areas, and thank everybody for their time. I think from the College of Surgeons' perspective, what we've heard this morning was that quality is a program. It's not a structure, it's not a process, it's not an outcome. It's a program that's part of a care model. And what we heard this afternoon were elements put together in a care model. Too often, as a payer, we get stuck in thinking about a payment to a hospital or to LTAC or to SNF or to home health or to the providers who are there. And we don't lace together a program like you heard today. And what we are saying from the college's perspective is that if we want to get to the next level of quality, to get to this expression of value, we need to work together with the payer community to develop a program like this. Now, this is the geriatrics, the frailty, the vulnerable surgical program. And just imagine that instead of measuring a point in time, we're measuring the programness around frailty. And we had the right measures in place that actually allowed us to secure the patient was moving into an environment that was wired for the condition they had, including the surgical condition they needed treatment, but their overall status as a frail patient. Otherwise, what we end up doing is we're measuring something in home health, which is a nice cross-cutting measure. It may have nothing to do with frailty or the patient. Then we're measuring something in skilled nursing or in a skilled nursing facility, and likewise with 10, 15, or 20 different providers who are touching the same patient. If we stop that, we didn't do that, and instead we said, all of us know somebody in our family who's frail and elderly going to the hospital for something. Where do they go that it's knitted together like UPMC? Where do they find that place that says, we happen to have the expertise for frail and elderly patients as well as a good program for total joint replacement? And when you put those two together, we're going to have the best outcome. And when you do that, it's a lot of measures, it's a lot of standards, but it helps the delivery system, it helps the doctors and the nurses and the pharmacists and the social workers turn to the CEO and the administrator and say, this isn't about checking a measure and getting paid. This is about success in a program. And that's what's missing right now, that we keep looking at quality as a measure when it's not. Quality is a program, and measures are part of the program, but it's only one piece of the program, and you have to knit them together. So our efforts would be take this geriatrics program that's been put forward and sit down with us and how do we map something that's cross-cutting for the geriatric frail patient in surgical care. And that, to us, would say, if you do that as a payer, we're going to embrace it. We're not going to sit back and say, don't be measuring us, because now we're actually building a team, we're building a program, we're dashboarding all these things that just got represented, and particularly the VA approach presents a dashboard to me, and I can react to that. But these isolated events that are occurring in quality measurement are not building a story, and I can't build a team around it. I can't get the CFO or the CEO's attention to get the resources for the program. So we absolutely need your help. That's our plea. Help us take better care of the patients by building a quality program like geriatrics, building a quality program around cancer care, building a quality program like you saw around trauma care or bariatrics. So those are absolute examples. Those are programs. And we know the resources needed to build it, and we know how to measure it, and we know how to put it together. We need your help there.
So I'd like to ask this wonderful panel, pretend you were a large payer and you wanted to measure quality. Would that be at the TIN level or sub-TIN or individual level when you're looking at measuring quality metrics?
So we have thought about this question of measuring at the TIN level, which is kind of what we do now. It's very high up. It's not at the program. It doesn't tell me what I need to do at the program level. And measuring down at the individual provider level, it's almost as if we still think that it's just Marcus Welby and the anesthesiologist and the case is over. And none of this stuff you just heard comes together. So something has to be done at the program level, at the disease level, and we think you can probably come to defining that at the sub-10 level. But it's not an easy question. There's a lot of technical, operational aspects of getting the sub-10 levels right. And so, but yet you're moving away from a hyper-focused, non-meaningful measure of an individual who's got low volumes, and it's really not that helpful. And you're moving away from this high level, how did the population do in general, where nobody reacts to that, nobody drives improvement on that. We've got to get to the program level, to the service line, to the condition and disease in the population. If we can do that using sub-10, great. If we've got to create another way to get there, fine, let's do it. But let's get this quality program wrapped around the patient and then put it into a payment program.
I think all our experience has been, the work that at the college has always been at this, what you would define as the sub-10 level. Programmatic, as Frank has said. We're now working together with the Harvard Business School and Michael Porter, and he talks about the IPUs, Integrated Practice Unit, and that is absolutely a sub-10 level. And so I think a lot of people, when they get something that works, it's at that level, because the 10 is too high. We can't do individual provider, and the sub-10 is the key.
Any other final concluding thoughts, Ronnie or Dan or Jason? No. Okay, well, anyway, thank you so much for this tremendous panel, all of your sharing all of your knowledge, practical as well as scientific. We really appreciate it, and thank you for joining today for all of you who are in the audience. Okay, excellent.
Nice work, guys. That was fun to watch. I enjoyed it.